Okay, so welcome everybody. My name is Jonathan Lovegrove. I'm one of the PMH EMS education officers for the region, and what I'd like to do is take a few minutes out of your time to go through the newly released OMD Care Map Acute Coronary Syndrome. So let's take a look and see what's new. First thing we've got is we have a newly released streamlined care map from OMD, which is really nice, and we're going to take a look at that in a minute. Next big ticket item we should talk about is the fact that PCPs are now going to be able to administer intranasal fentanyl when patients have ACS type symptoms. So that's a really good addition. As well, I'm going to share with you some updated dosing guidelines for ASA. The next thing we're going to look at here is the change in systolic blood pressures in terms of nitroglycerin administration. So we'll go through that. And then the last thing we're going to talk about briefly here is we're going to talk about fluid bolus for these patients that are hypotensive, either because they are hypotensive with ACS or because we made them hypotensive. So let's take a look at the care map. Okay, so this is E04.1A, acute coronary syndrome. I've kind of blacked out most of the care map, so it just makes it easier for us to focus on what we're talking about here. So let's start at the top, work our way down. Number one, ensure oxygenation. No big surprise to anybody here. 92% SpO2 is our targeted goal there. In terms of the ASA administration, you definitely can see there between 160 and 325 is your dosage guideline now. So it's definitely changed a little bit. So if you want to give somebody 4 ASA tablets equaling 325, then that's something that you can do. You're still okay to administer 160 to everyone, in fact, if you need, if they have ACS type symptoms. So the 325 just gives you perhaps more flexibility. In terms of not repeating the ASA dose, unfortunately, I'm just the messenger, please understand, but we've come full circle on this. So we used to say that if the patient took ASA and you could validate that, then you didn't have to repeat that. And that's exactly where we once again find ourselves. So if you know that they took ASA and they crunched it up and swallowed it, then don't need to repeat our ASA. So good common sense condition applying there now. Next thing to look at, acquisition of a 12 lead ECG and or 15 lead. And ICPs, the expectation is that you're going to be able to interpret these as well. I mean, just to begin with, not everybody has 12 lead capable machines. We know that, we understand that. If you do have a 12 lead capable machine, it's definitely in your best interest and the patient's best interest for you to acquire that before you give the nitro. What you're looking for at the ICP level is you're looking for an RVI, or elevation, in the V4R lead. So you got to take your V4 precordial lead and you're going to move it over to the right side. The same place as on the left, you're going to move it to the right. What you're looking for is elevation of 1 millimeter. That's one little tiny box on the EKG charting. If it's more than 1 millimeter of elevation in V4R, then most likely that patient has a right ventricular infarct. And in that case, you would withhold any nitrate therapy. Okay, and that's only if you have ICP level. For everyone else, the expectation is that you just go forward and administer the nitro. So let's see how that goes here. So what they've done here is they've taken out the bypass information for ACS type patients. That used to be included in this protocol. It's now been taken out, so that gives us a more streamlined care map here. In terms of administer sublingual nitroglycerin, just be aware that at the EMR level, you are unable to administer the nitro patch. So EMRs are only able to administer sublingual. And what we'd like to say is that the nitro patch, it's optional. We've had the ability to give the nitro patch for some time now. We see that as a really optional part of this protocol. What you need to do, number one, is you need to stabilize this patient, and that's by giving them high doses of sublingual nitro spray. Each spray of sublingual spray gives 400 micrograms or 0.4 milligrams each time, whereas the nitro patches are a very slow release, and each patch is 200 micrograms per hour. So we're talking extremely low dose. It's not really appropriate to just rely on those alone. We see it as more stabilized than with the nitro spray, and then hopefully get the patient's pain right down to zero. And if it does come up a bit, then you can kind of maintain that with a nitro patch. That's how we see it. However, if you want to incorporate it sooner into your protocols or into your management of these patients, that's okay too. One thing that's changed here with nitro for everybody is that the systolic pressures, the bottom number has now gone down a little bit. So you can administer nitro spray or patch to someone who has a systolic blood pressure of 90 millimeters mercury or greater. What we want you to do is not administer if it goes below 90 systolic, or if you have a drop of more than 30 systolic. Then you're not going to administer any more nitro. And just so you know, PCPs are kind of new to the moving on to fentanyl in this care map. So generally the general guideline is that you administer nitro spray 3 times before moving on. That is, unless maybe you give 1 spray and you have a significant drop in blood pressure. Obviously, don't do it again. And if the patient's blood pressure goes too low, then you need to give them fluid. And we'll talk about fluid in a second here. So, continuing down the care map here, we've given our ASA at the top, we've looked after 12 lead, we've considered nitro, probably administered at this point, and then we're going to make some decisions. Has the patient's pain been relieved with the nitro? If it has, you're going to transport. If it hasn't, and we say roughly after about 3 administrations of sublingual nitro, that you can consider fentanyl for PCP. ICP, you guys still have the option to give whatever opioid that you like in whatever route that you like. And we will talk a little bit about dosing of intranasal fentanyl in just a minute. The last thing on here is the fact that there's very bottom right, administer intravenous fluid until systolic blood pressure corrects. So that's if we perhaps give them nitrate therapies and they are preload dependent. Most likely they have a right ventricular infarct. If that happens, if you haven't already started an IV, start one quickly, and you want to administer fluid. So the goal that they have for you to achieve that is 10 mLs per kg in 500 ml boluses. Reassess at the end of each time. Keep going until you stabilize that systolic pressure. And that's our new care map in a nutshell. I just want to kind of go over very quickly the new ASA med page. So this is M37.1. Again, you can see the dose, 160 to 325 milligrams by mouth. Get them to crunch it up, num num. Wonderful. The indications, no change. Contraindications, no change there either. Okay, so let's take a look at our nitroglycerin dosing here. I just want to review this, and I do want to point out pretty clearly here, just to let you know that the medication page has not been changed to reflect the changes in the care map, which now allow you to administer nitro down to 90 millimeters systolic pressures. So just be aware of that. So it is okay to administer nitro right down to 90, okay? The med page is not going to reflect it. Sublingual dose, 0.4 milligrams every 5 minutes until the pain gets to 0, or until you've tried it about 3 times and then you move on perhaps to an opiate. Topical dosing, it goes by systolic blood pressures, so 100 to 150 is 0.2 milligrams a patch, 150 to 200, they get 2 patches equaling 0.4 milligrams, and if their pressures are greater than 200 millimeters mercury, they get 0.6 milligrams per hour. So just remember, keep in mind at least that nitro affects everyone a little bit different, at least in terms of the nitro patch. The absorption pattern from one person to the next is going to be a little bit different. However you give it, just keep in mind that it's a really slow release type administration. I just want to quickly review intranasal fentanyl dosing with you here. So ICPs, don't get alarmed. I didn't include morphine here. You're still okay to give it, and as well, ICPs can still administer fentanyl via any route that they choose. The reason why I've got adult only listed here for fentanyl is simply because the ACS algorithm only allows you to administer fentanyl or treat those patients if they're an adult, so greater than 17 years and older. So common sense, makes sense. Just remember that anytime you're giving an intranasal administration, no matter what the drug is, it's given in an undiluted format. So key to remember there, just draw up what you need from the ampule and administer that. Whatever remains in that glass ampule, you still need to put it somewhere secure. So it's not okay just rolling around in a broken glass ampule or taped to the side of the truck or something like that. You need to draw up whatever remains in your ampule into a syringe, label it, and then cap it. That's best practice. That's it, everybody. We've made it to the end here. So if you're listening to this now, we can almost guarantee that we've already gone live with this protocol. The implementation date is December 1st of 2018. Just a reminder, if you haven't already done so, click that you've read the memo once you've read the memo and or once you've viewed this and you're comfortable. If you're not comfortable and you have any questions, as always, please contact one of the EMS education officers and we would be more than happy to be able to help you with whatever questions you have. Okay, thanks everyone again, and hopefully you found this useful and informative.